everyone. My name is Samantha Weaver, and I'm the director of the AOMT. I know we have some more people coming in. It's great to have everybody here. I have a feeling there's going to be a lot of us. So what we're going to do is, if you could just make sure you're on mute. The reason why we don't convert these to webinars is because we really want you to be able to see each other and kind of feel the energy of everybody coming together. And I know we have a lot of people from all over the world today. So I want to just say thank you for coming. I know many of you are clinicians in the dental field, maybe you're in the physical therapy field, the speech, and you may know what we do. We provide training and mentorship around myofunctional therapy and sciences. And every Saturday we have our meeting here. It's called the Myo Coffee Klatch. It means to get together. And it's basically just going to be, it's a chance for us to share ideas and all sorts of things. So today is a very special event. We've opened it to the wider audience. If you would like to be involved in future mailings, I'll put up a link in a little bit. And all that means is we will hold other events just like this in this fashion. And we are, we welcome your engagement, participation, etc. So today we have Dr. Bill Hang, and we are so happy that we get to know and work with Dr. Hang. He has actually been a big proponent of understanding function and really validating the work we do as myofunctional therapists. And he has more passion than everyone in this room, if that's possible. So I think you're going to feel it, his engagement with his patients and his care. And he and Debbie, his wife, have been such a huge part of our own unfolding in reaching and communicating to patients better about the important role of optimal breathing, optimal function, and how to change one's trajectory in health and in life. So we're really, really honored that you're here with us, Bill. What I'm going to do is facilitate questions at the end. So he will go ahead and present, and then we'll have about 15 to 20 minutes for questions, and we welcome them. So Bill, thank you again.
Thank you so much, Samantha. It's really nice to be able to share some of my thoughts with people today. And I am a huge advocate of myofunctional therapy. I went from being someone who was taught in orthodontic training. It was like selling elephant repellent to people when nobody's going to get trampled by an elephant. It was not well thought of in my orthodontic training. But over the years, I realized that if we were to learn anything in orthodontics, we need to learn about rest oral posture. And so I'm a traditionally trained orthodontist. I took out teeth by the truckload back in the 1970s. And about 40 years ago, I said I couldn't do that anymore. And I've been on the continuing education path really since then. It never ends because you learn more and more and more. So what I'd like to do today is to share some of the thoughts of what I think is terribly important in healthcare in our country right now. Another way to put another title to this is what I call dentistry's new role in the future of optimizing health span. And wouldn't it be lovely if our health span was exactly the same length as our lifespan? But so many people don't have that happen. And so they end up lingering on with big problems. And we'll talk about some of that today. But the real focus today is going to be really on the younger children. My wife and I came up with this Ortho to Health. It's really a completely different profession. And myofunctional therapy is a critical part of this whole thing. It's all about airway. And when you really understand it, airway is everything in dentistry. Sadly, the profession doesn't quite understand that yet, but my goal is before they lay me to rest, I want to change that. So we will have time for questions later on. And this is one thing I want to thank John Mew for, many things, but this simple measurement here can help you and me and anyone else who really understands it predict who's going to have great facial growth, and as part of that, they're going to have proper, good airway, because proper facial growth and airway tend to go together. You have a well-balanced face, you're going to have an airway that's wide open. A well-balanced face is a face that has grown properly forward. So John came up with this measurement many years ago, and there's a picture of John. For those of you who know him, you know him well. And when I first heard about it, I was very skeptical. I'm kind of a born skeptic. And here's what it is. You measure from the tip of the nose to the edge of the upper incisor at any given age. And for a male, that number should ideally be 23 millimeters plus the patient's age in years. So we're dealing now, what I'm really going to focus on is the kids under age 6 even. And I mean, orthodontists don't even want to bother seeing anyone until age 7. In reality, we're going to show you soon that many of the kids have brain damage, but by the time they get to school, by the time they even have any permanent teeth in, they have brain damage that's going to affect them for the rest of their life. So for a female, that number is 21 millimeters plus the patient's age in years. And you start, if any child who has a measurement that's more than 5 millimeters larger than that has got a face that's not going to grow favorably. And you're probably going to be easily recognizing the signs of that with the lip apart posture, usually flaccid lips, accentuated cupid's bow, all the stuff that you in myofunctional therapy do on a daily basis. You're going to see this happen. But by using this number, you can document it and predict it. For instance, here's a classic patient of John Mew's. You see the little girl on the left-hand side, and if you were to measure that at age 6, you could say this is like a 3-alarm fire that's ready to happen. And by age 9, you can see that it's already happened. That cute little girl turned into that girl on the right-hand side. The number being way too large at age 6 is already unfavorable facial growth, and now you see her on the right, and she's had a lot of unfavorable growth. So you say, well, what's the big deal here? Why do you care? Well, care a lot. And so here's a young man who comes to see me, as many do. He's had someone tell him that he needs to have 4 teeth taken out. And I, of course, quit taking out teeth about 40 years ago. So it's no big deal for me to treat him without taking any teeth out. But the big thing here is I say, you got to get myofunctional therapy because your mouth is hanging wide open, your face is going to grow long, and that's not going to be good. So we easily straighten his teeth. That's no big deal to do. And this isn't about straight teeth, but he's still a mouth breather, still has poor restoral posture. I actually referred him to Barbara Green, who's on this call, and I don't think they ever went. So his face fell down back, and what you see here is his face when he's in his mid-teen years. And you have the Bolton norm, which I explain about what that really is, but it's kind of an ideal face that we got from a study at Case Western Reserve University back in the 30s and 40s. You superimpose it on the forehead, on the bridge of the nose, and you can see how the faces fall back from where they ought to be. And it's a great, useful tool. We use it all the time. And when you look at his face, he doesn't look that different than anybody else's age. I mean, he's a very normal, quote, normal looking child. That's what we're raising. But if you see this video here that his mother took with her cell phone, there he is sleeping, and you can see his mouth hanging open like 25 millimeters. He's snoring. And what do we know about snoring? Well, I've learned a lot about snoring. Snoring's not normal. Snoring should never occur. That's from David Gozal, past president of the American Thoracic Society. Anyone who snores will develop sleep apnea if they live long enough. Well, he doesn't have to wait very long, because here he is at 15 and he gets a diagnosis of sleep apnea, and that's his airway. And you see it in a minimal cross section here behind the soft palate, and that's a very small airway at that region. And we know from David Hatcher, the oral radiologist, that this young, if he were an adult, we kind of could call him that at age 15 almost, that he would be at a fairly high risk for sleep apnea. We know he has sleep apnea. You say, well, that's no big deal. He can wear a CPAP machine for the rest of his life and he'll be just fine. And my response to that is, oh, really? Because here from the New England Journal of Medicine, almost 6 years ago, study came out that CPAP does not provide a statistical benefit of reducing someone's chance of heart attack or stroke, which are the two of the biggest things that are associated with it. So, sleep apnea is associated with every chronic disease known to man. But if you think that wearing a CPAP machine for your whole life is going to save you from this, well, good luck with that. So another really big name in sleep is John Remmers. He's retired now, Harvard-trained physician. And he talks about the structural narrowing being the big deal. And if the jaws were forward where they're supposed to be, then he says it would not exist. Now that's where my big thing is to try to help the structure. And if I can get the structure where the face grows forward better, then the airway is better. Of course, you all know, and this is your bailiwick, that muscle tonicity is a huge part of this whole thing. And if you can have the biggest airway in the world, if you don't have good muscle tonicity, you can still have apnea. So everybody has to work together here. And that's why I'm such a big advocate of myofunctional therapy. So let's look deeper into this subject of apnea. And Karen Bonnick's study from 2012 is a huge one here. She talks about the behavioral aspects, what happens here to these people, the fact that many of them are going to need special education. This is new, and it confirms what we've actually known for a long time. Phil Cooper is a good friend of mine in the American Academy of Physiological Medicine and Dentistry, practices in Savannah, Georgia, and he's on the board of the AAPD. He's written this book. He serves a lot of African-American kids, and this is the book that he wrote. In reality, what he's talking about here really doesn't relate to the color of the skin. It really relates to these many kids, at whatever race they are, getting to first grade, and they've already had sleep apnea, they've already got brain damage, and they're not going to read well. Their future is already impacted badly. Other medical issues here, you can see platelet aggregation that is associated with sleep disorder breathing. And just in case you think, oh, this is all new, hello, this is 1909, and you can see brain development's retarded. There are articles that go back into the 1800s, and this has been known for many, many, many years. It's just been forgotten and pushed off to the side in our profession, while the orthodontists, want to align lower incisors once they're all in. And you can see other things going on here, brain injuries that affect everything. One of my favorite authors is Ron Harper from UCLA, and he has MRIs done on kids who have even one night of reduced oxygen saturation. He can document things that are going wrong here in their brains, and he's published on this. When you hear him lecture and you see these statistics, then you really understand that this is a big deal, and how can we ethically and morally really turn our back on it? I mean, from my perspective, this is an ethical and a moral issue. I see the world through black and white. To me, things are black or white. It's either right or it's wrong, and there's not a lot of gray in my life. I'm an Eagle Scout. I'm proud to say that, and I look at the world in that way, and I can't sit back and let kids not just get brain damage. So let's look at somebody here, and again, let's look at this Bolton Norm and see how her face is back. And we measure the cosmetic line here, which is that number from the tip of the nose, the edge of the upper incisor, and it's 7 millimeters too high. And you can see how the Bolton Norm confirms that her face is back. Now, this girl has already been diagnosed with sleep apnea, and that's her airway. My point here is you use this measurement, the Bolton Norm and the airway, and you look at it all together, and most of the time, it all goes together. So when you see a face that's back that far already at this age, you're going to see a face that's got a pretty poor airway, and that child is going to struggle to breathe. So in our profession, what's in our bag of tricks here to do this? Well, The knee-jerk reaction in our profession is to expand laterally. And of course, I believe passionately in expanding laterally. We expand both arches, even though I learned that the lower arch cannot be expanded. I learned that in orthodontic training almost 50 years ago. But starting in 1985, when my little boys were of that age, they're now 46 and 44, I began expanding them because I met an orthodontic department head who said it could be done. So I decided I needed to try. And now I do it for a living. And yes, you can expand the lower arch 10 millimeters easily, and you're not going to push the teeth off the bone support. So, but the big thing is in the AP plane of space, we want to develop the face forward. And that's where you come in, because you are critical in this process to get proper restoral posture as soon in life as is physically possible. I mean, age 2 and 3 or whatever you can work with these kids. That's when we need to get this job done. Let's give you some examples here of fathers and children. Here's a father who's had 4 teeth taken out. He's got blood pressure that's nice and high, and he's had cardiac events that, he nearly died. And he states that he can't even breathe when it's cold out. And he needs surgery to advance both jaws, but he's not going to get it done. So look at his face. And he's really not even that far back from the norm, but his airway is lousy. And there it is. This is not an airway to grow old with. This is an airway to die young with. And again, the exact size of the airway is not diagnostic of sleep apnea. But if you were able to choose your airway, you'd always want the biggest one you could get. This is his daughter. And if you look at her teeth, she's got 2 lower front teeth coming in, and she's got a very deep bite. So dentists would focus on, well, do we treat now or do we treat later? The fact of the matter is, forget about the teeth. Her lips are apart all the time. And her upper front teeth are down already about 10 millimeters from where they ought to be. And it's too late to treat her in the primary dentition because the upper front teeth are gone. So you can see how far back she is already. And now here she is when she has her permanent teeth in. And now we can start the process of what we call orthotropics. This is not something that orthodontists are taught to do. It is what John New teaches, and I've been teaching for many years, been doing it for 32 years. Now, it's the diametric opposite of traditional orthodontics. Instead of pulling the teeth back and retracting, we move the upper teeth forward. So here you see we do the unthinkable. We push these teeth way out, make her look really quite awkward. You have to have some real fortitude to do this, and you have to tell the parent what you're going to do, but it works. Then we develop the mandible forward with an appliance that negates the headgear effect, and I explain all of what that is in my mini residence or in my new mentorship. But the face develops forward, and you can see on the right how close to the Bolton norm she comes by doing this at that age. If we'd have done it in the primary dentition, we might have an even better result. But the big payoff and the icing on the cake really is what happens to the airway. And you can see that how much her face has moved forward, and you can see that her airway is opened up maximally. And her mother, when she saw this, was amazed, and she started to cry. She was so happy. Told me how the girl's doing better in school, 2 years ahead in her coursework, and all the good stuff is happening. And then, of course, I show this because she's on the circuit. This family travels all over, and she rides horses and she competes. And I say to you, do you think she would have gotten that smile had we not done what we did? And she looks really healthy there in that picture. She doesn't seem to have the little dark circles there anymore under her eyes. Here's another child, daughter of a hygienist. And you can see, we call this a class 2 division 2 malocclusion. And kids like this are frequently given headgears. I had one of those women come in this week, given a headgear. She's in her early 30s, and she has sleep apnea. She's probably 6'1" and very slender, no extra weight on board. She has sleep apnea, not your usual NFL linebacker that's 300 pounds and got sleep apnea, a slender woman. So it's a big deal to treat early here. So what do? We take this little girl whose face is back already, and we move it forward. And here she is 3 years later, and the spacing that you see will close on its own. She never wore braces, and her never needs retainers. Her face has moved forward dramatically. In this picture on the left, you can see her with what I call bozo lips. She's licking her lips all the time, and it makes it red all the time. And of course, this is, all this stuff. But look at when she's finally got her lips together and breathing through her nose and not doing any of those noxious habits, her entire appearance changes. You can see what she got out of it. Many of these cases, we don't take lateral head x-rays on our patients after treatment anymore. We just can't justify that radiation. And so you're not going to see x-rays on all of these. But not everyone needs to have their face developed forward. We can have just lateral arch development. So you can see my family. This is our last holiday card. You can see on the left, my son, David, who's 46 now. He had arch development in the mid-1980s. And my son, Daniel, over there, he's 44, and he had arch development. Sadly, he looks like me, but that's okay. Then we have our son, Magnus, our grandson, Magnus, who's David's son, and he had arch development done. He had the world's biggest teeth and the world's smallest jaws. And I had it done with one of my students in Suffern, New York. David lives in Greenwich, Connecticut, and there's a zillion orthodontists there. And David and Ingrid drove him an hour to see a general dentist who I trained to do arch development, because there's no way it was going to happen in Greenwich, Connecticut, unfortunately. So we go to great effort to do this, but it's worth it. And Magnus came out to visit over the holidays, and he's 12 years old now. And I said, "So are you happy with your smile?" "Yeah." "You want to wear braces?" "No." I said, "Right answer. That's great. I don't want you to wear braces either. You look great." No retainers, anything, but we expanded 10 millimeters of both arches. And here's a classic kind of a case of a girl who is crowded in both arches, and her face is really quite forward. Her cosmetic line is almost on the money, only a millimeter back or whatever. You see the Bolton norm, and so she's really much better than a lot of kids her age. And her airway is better than an awful lot. So here is lateral development of the arches. And we push the teeth forward, and you see that we've pushed the upper incisor teeth forward. So there's a space between the lateral incisor and the primary cuspid. Those 3 teeth on the side will go away in the next few years. And when we finish this, there will be more than enough room for the permanent teeth to come in. Every arch development case we do, there will always be enough room when we're finished to have the rest of the teeth come in. And at this point, we're talking to the patient. If they haven't had myofunctional therapy, we've referred them. Maybe they've had it, maybe they haven't. Sadly, so many won't go, even though we refer it. And you know how that works. But we do all the kinds of things to try to get them to get their lips together, because when we do that, then what we've done here is going to be nice and stable. If they get their tongue to the palate and keep it there, the tongue is a pretty good retainer. So there you see it on the lower. So here we go. You can see her smile's improved a lot. But let's look at some more parents and kids and see what really matters here. Here's a guy who's got apnea, and here is his airway. And here he has no apnea because he's had double jaw surgery to advance his jaws, and he has no apnea. You can see how far forward he was brought surgically, and that was enough to get him done with apnea. This is his son, and we can play orthodontist and focus on the crowded teeth if we want, or we can actually want to try to develop his face forward. And this is what we've done for him. And look at his airway to start with. This is a paltry, tiny airway. And so you see how much just in 1 year before his upper incisors came in and we could treat him, how much his face fell back. And that's what we're trying to prevent. That's why we want to get the proper restoral posture as soon as possible. So here he is after we've done the orthotropics. He's had no phase 2. Yes, he's got some crookedness of his lower incisors, but I check the obituary columns and no one ever dies of crooked lower incisors. So I'm not too worried. If he wanted those straightened, it's easy to do. But look at what we were able to do with the orthotropics for him by developing the face forward. Then compare that, his face after our treatment with his dad's. You say, wow, so this is basically what you've done here is you've done non-surgical development of the face, really surgery without a scalpel. Here's another father, and he ignored, I told him he had apnea, he better do something, and he didn't do anything. And then he gets the stents placed in his arteries of his heart. Here's his kid, age 5 years, 5 months. And this is my motivation. This patient is years ago was my motivation. Seeing these slides will help you understand why I said we must treat in the primary dentition. So the reason what happened here was I told the mother that he needed orthotropics, and the older sister was doing it. And she said, there is no way on God's green earth that he's going to do it. He's not going to cooperate that well. I said, fine, we need to wait for the upper incisors to come in, which we did. In his case, it took forever. Here he is, almost 11, and finally gets his upper incisors in. Those upper incisors usually come in a girl, 7.5, 8, 8.5, 9 at the latest. And for boys, somewhere in there, but 10 years, 11 months is super, super, super late. My reason to show you this is see how much his face has melted down in those years. It's literally melted away. And so we're starting way behind the 8 ball when we do our orthotropics. And you can see that we're able to get him forward some, but not that much. When there's a deep bite like that, those upper incisors basically act as a roadblock to forward growth of the face. And so you must move them forward. And if you don't, this is what you're going to have happen. And this would be a great case to have treated early and had myofunctional therapy done, because a child like this will hold the tongue between the teeth, which is why the front teeth over-erupt and get into this deep bite, effectively trapping the lower jaw. So here he is. This is what happened afterwards. After the orthotropics, he really didn't get his posture corrected well, and his face melted down some more. Comparing his face when he's 18 to his dad, I kind of say, wow, this is, I hope he doesn't go down the path that his dad has. But the point here is what would have happened had we really been able to treat him at age 5 in the primary dentition. So what we've had in orthodontics in the past is basically, fighting forest fires. And it seems to me a little bit more, sensible to be, as soon as you smell the smoke and you people understand what the smoke is, you can see the poor rest oral posture and start treating early. So from my perspective, the ortho to health is a completely different profession. It is not orthodontics. Orthodontics is fine if you want your kids' teeth to be straight. Good luck with that, So in treating in the primary dentition, here we have the best patients that are ever going to be treated in the primary dentition are kids of women like this. A woman who's had 4 teeth taken out. Now, this woman drives 3 hours from near San Diego to see me. There are a few hundred orthodontists she could see along the way. But I reopened her extraction spaces for her, something that I've been doing since 1989. And I got rid of her headaches and her sleep problems. And she's got a nice broad smile. So she will move mountains for her little kitties to have something better than what she had. So we select the family when we're going to treat in the primary dentition. So here's her daughter who has 110% deep bite. Those dentists who treat TMJ patients know this girl is nothing more than an accident looking for a place to happen. 99.9% chance she'll develop, in my opinion, she'll develop TMJ problems. But look at her smile. The upper teeth are massively down already because of her poor rest oral posture. That's a gummy smile. In her smile, the teeth are down below her lower lip. You're just seeing her gum tissue. So she's got full roots on those teeth. So we blow them out, make them stick out like crazy. And then we bring the lower jaw forward. Here she is later. If I were to treat her again, and this was years ago when I was treating her, I would have expanded, I would have done arch development on her. But this has been an evolutionary process of me learning, because no one taught me to do this. I was out there literally experimenting, doing this stuff because I felt I had to. I simply couldn't just watch these patients go down the tubes. And I'm teaching this now I haven't taught it earlier in treating the primary dentition because I wanted to have lots of patients and I wanted to see where it all ended. I didn't want to have problems and then be teaching other people to do it and have them have problems. I believe this should be the future of orthodontics. So here she is later, and she actually came in the office this week and all of her teeth are in and could line them up. There's a little crowding there, whoop-de-doo. But her face came forward nicely. The gummy smile is gone. And you can look how accurately that cosmetic line measurement really shows where the teeth are. Now, it looks a little weird to you in that picture on the right, but it all works out. So her face came forward quite nicely. And again, I don't have an x-ray to show her airway. But believe me, here's kid number 2, and I've treated kid number 3. I won't show him. He was just in, and the pictures aren't ready. I was just in 2 days ago. But she's way back already, and mom has witnessed apneic episodes. So she's like 12 millimeters back from where she ought to be. And you can see her face is really falling back. And that's a face, you can see how it's beginning to lengthen. This girl is going to have a very long face and not be attractive, and her airway is going to suffer for it. So we do our thing, push the teeth forward, and then develop the lower forward. Here she's of course lost her front teeth, looks kind of weird. But you can see the development that you can get. And this is not easy. This is hard work. Requires a lot of effort on the patient's part, and the parent has to be totally supportive. So this is a really cool case I like to share because it's one of the ones that just warms my heart. This little boy comes from Chicago, referred by Steve Sheldon at Lurie Children's Hospital, head of the pediatric sleep clinic there. And this little boy has a syndrome, Pierre-Robin sequence. He's got a diagnosis of sleep apnea and failure to thrive. And so we're going to do our thing for him. And his mom and dad flew him out many times from Chicago to see me. And you see the airway improvement we got, going from a lousy little cross section like that. And Steve Sheldon calls me on the phone one day and says, Bill, I got great news. We did our sleep study for Ryan, and he's completely free of sleep apnea. Steve then spoke to the Illinois sleep doctors and said that Orthotropics was literally the most important thing that he'd seen in his entire career. And that's a book that he's published in terms of to be able to help young kids. And Kevin Boyd from Chicago then published this case, and those are the same x-rays you saw. And this is published in Steve Sheldon's more recent book, that here we have a kid who got rid of his sleep apnea completely. I wanted to follow up on this, and so I did just last fall. I contacted the mother, and they'd moved to Colorado, and this is what she said to me in her email. And there's Ryan, that same little boy, and he's doing very well, all because of the Orthotropics. He's 17 years of age. Just this week, Kevin Boyd emailed me because he'd seen a previous version of this that I'd done, and he wanted to comment. He had just started the mini residency in my office when he went back, and he was on the panel at Lurie Children's Hospital. And there was an orthodontist there who was examining Ryan and looking at the appliance, which was weird looking, that was in his mouth to bring his lower jaw forward. The orthodontist said, this won't work, and we need to schedule this boy immediately for jaw surgery to advance his jaws. And Kevin said, oh, I've just been to Bill Hang's office. I think this will work. And so the orthodontist said, okay, I trust you. I trust you, Kevin. And so after the sleep study was done and there was no more sleep apnea, the guy said, well, I guess we don't need jaw surgery. Do you think that the orthodontist contacted me to find out how this could be done so he could help other people? Well, I think you know the answer to that. And the answer was no. So here we did a study on what is the effect on the airway. Now here's the patient you see here is a class 2 patient, and we advanced her upper incisors 8 to 10 millimeters and then advanced her mandible, and that's exactly what happened to her airway. In our study, on average, we got 31% improvement in the airway between the soft palate and the back of the pharynx, 23% at the angle of the mandible, and even down the laryngopharyngeal area, some improvement. Now, I never promise anybody resolution of any symptom. I've never promised The only thing I ever promise is I say I'm an Eagle Scout, I'll do my best. And if they get better, that's great. I'm happy. But go back and remember now what John Remmer said here. It's all about the anterior posterior plane of space. So let's look at what the usual stuff is that happens here. And it's usually about just expansion. So here's one that's had alpha appliance, and he's still got problems. Nothing wrong with the alpha appliance, great way to expand, but a lot of width there, still not okay. Here then is a patient who's 43 millimeter intermolar width with the alpha, a great expansion, and she not well rested and may have apnea, we don't know. And one of her goals is to have her chin forward. Well, I don't have any way to get her chin forward when she's got all of her teeth in, like that. But the only way to get her face forward is surgery. That is her airway, which is good because it's better than most, but from a symptom perspective, she really doesn't sleep well. This is her brother. This is a monstrous, beautiful expansion. John Muse says you need to have a 42 millimeter intermolar width for you to get your tongue to your palate. Well, hello, this guy's got 45. But he snores and he may well have apnea, and that is his airway. That's not an airway to grow old with. And that's how far back his face is. But look at him. Does he look different than kids in your school? He may not look different than some of your kids, but think about what's going to happen for him. Here's another one. All these I've not treated any of these people. Here's a 38 millimeter intermolar width, restless sleeper. You see what's going on here. Has a sleep study, desaturates way down, but nobody says do anything. Really? Is he going to grow out of this? Oh, let's give him some drugs. That'll help. Drugs are always the answer. Again, he's not an outlier. He looks like a zillion other kids, but look how far back his face is from where it might be. This kid is diagnosed by a summer camp counselor who notices that he's stopping breathing every night. Way too late for us to do our orthotropic thing at that age. So all we can do is to expand both arches, and that's what we end up doing for him. You can see he's back like that, and that's his airway. That's basically like having a cocktail straw to breathe through. That's it. That's not an airway to be healthy with. We're not going to have a good health span here unless something changes. We expand because that's our only thing we got, the only show in town for him, and we expand 10 millimeters, and we improve the airway, minimally, big deal. And then we put in an appliance to advance the front teeth, push them forward. And his mother says, okay, he's better, he's sleeping better with no apneic episodes, she thinks. And here he is later on wearing some retainers. I've done the best I can do with what I had to do at that time. You can see him here, and he has sleep apnea. We had a sleep study done, and he needs surgery to advance his jaws if he's going to have a good life. We can't do surgery on all these kids. It's ridiculous. But you can see how far back his face fell just in that time. So, like I say, it's all in the anterior posterior plane of space. We must be operating in the AP plane. And yet the mantra in my profession, for those who even care about airway, is expand and expand and expand. So here then we have a little boy, and let's be honest, who wouldn't want to treat little kids that look like this? It's like a puppy. You want a puppy to never grow up. They're so cute. But he's got a big problem. And all these things that I'm showing you here, his mother is telling us. And so, he's really not okay. And he gets the tonsils and adenoids taken out, but he's still got problems. So we end up doing arch development. And again, look at this really deep bite with those upper incisors that look like they're pushed back, because they are. And his face is back. So we did arch development for him to expand him like crazy. And you can see how far back his face is. He's not even 4. So having seen those other cases, you're going to think, oh my gosh, what's going to happen here by the time he grows up? And of course, my feeling is it's not going to be good. So we've done the expansion. You can see here how we've expanded both arches. And please notice that he has no permanent teeth in there at all. For those dentists here, you can also notice how pushed out those primary teeth are. But the point is, we've developed the bone out there, and the primer and the permanent teeth that are in there are going to erupt in that bone in a wider stance. So we've made a permanent change here for him. This is not the standard of care in the profession. I wish it were. And hopefully before I'm laid to rest, I'll have it become the standard of care. And I want you to help spread the word and find orthodontists who are open-minded, general dentists, pediatric dentists to work with to do this. The stakes are too high just to sit back and do nothing. So here he is after all of this. So we haven't taken a sleep study. I don't need one. Why? I know he's got a problem. His mom, he's still tired and he's still hyperactive and irritable. So that's enough for me to continue on. And so we say, okay, we've done the arch development. Now let's push the teeth forward and see how he's fallen back even while I did the arch development. Here we go. And he's in treatment with me now. And he was in this last week. And I have the upper front teeth fully forward where they're supposed to be. Much further forward than this, by the way. You got to really have strong knees so that your knees don't shake when you do this. So here then we have an article which basically confirms what I'm saying to you. This is from Christian Guilleminault. And what does it say? You can expand, and that's great, but it may not cut the mustard and help you with the sleep breathing problem. So just to show you for one final time how closely correlated the cosmetic line is, this girl on the left, you can see, is only 2 millimeters above the ideal, and see how closely her Bolton norm is on her face. The girl on the right is 15 millimeters above the ideal, and her face has fallen back massively, and she has a horrible malocclusion. So it's not tonight, but this morning. So I've hopefully given you reasons to treat early and an overview of what is possible and tools you may not have had before in making this measurement. For orthodontists and dentists and general and pediatric dentists, it's not about the appliance. That's not what it's about. You got to know what to do. You got to know what the problem is. You have to know why the problem exists, and it's always going to be a rest oral posture issue, which is what your deal is. You help kids have proper rest oral posture and become nasal breathers. And you've got to know what can be done. And what can be done here is not being taught in the ortho programs. I can tell you that. And there's no cookbook. Don't I wish? It actually requires thinking, and you have to be open-minded. Really to new things, which I was not early in my career. It took me a long time, and I've gone through a very, very painful learning process back in the 1980s. But at this point, I'm here. I've got all this time behind me, and my goal here is to help good folks like you understand what's possible and get teams of people to work together. I don't do this all alone. I can't. It's a team effort. Myofunctional therapy is critical in this whole thing. So that's what I have. It's taken me 45 minutes. We got some time here for some questions. So I hopefully you have lots of them, Samantha.
Yes, absolutely. Thank you so much. I know we have, I know there's some questions in the chat. And if you do have a question, can you put the Q on there? Because I know there's some other chatting. One question, people were asking about the Bolton norm.
Yes.
And if you could just explain a little bit more about that.
Okay. Back in the 1930s and 40s, in the United States government and many scientists, and including a United States president, were into eugenics. It wasn't just Adolf Hitler who was into eugenics, the perfect Aryan race. There are people that were saying we need to have people more attractive and whatever. So it's hard for you to believe this, but it's true. And so at Case Western Reserve in Cleveland, Ohio, there was a study done, and only one part of it was to take pictures of very attractive kids. They took head x-rays of Caucasian children that they deemed very attractive. And they took head x-rays starting at age 8 to 18. And I actually, when I practiced in Vermont, I had a mother in my practice. I was treating her kid, and she was actually part of that what was called the Bolton brush study at Case Western. They also took X-rays of the wrist, and how that really compiles numbers came from that. And so they put together the Bolton norm. Was an artist came together. This was the composite of the X-rays to show these well-balanced faces. Now, I'm the one who began superimposing that norm on the face, because John Mew would always show how far back the face would be with what he thought the face should do. And our faces from the right here to here are pretty similar, from the middle of the nose right here. But as the face falls down and back, the cheeks flatten out. The tip of the nose will drop back like this, making the nasal bone look like it's bumping out. In reality, the nasal bone is perfectly normal. But that's what you see as the face falls down and back. And with a Bolton norm, you can show this really, really well. Many of the people will tilt their head back as they're looking forward. You take a picture of them. They're just trying to stay alive. Their head is tilted back, and they have forward head posture as well, which you all know, because they're just trying to breathe. If they had their forehead straight up and down, vertical the way it's really supposed to be, their chin would be so far back they couldn't breathe. And if you shove their head, which is 2 or 3 inches forward like this, back, then their airway kinks off like a garden hose. But the Bolton norm is a great way to illustrate to the parent what's really going on already.
And if people wanted to use that tool to show, you created your own, correct?
I mean, you can measure it. You really just need a Bowley gauge. That's all it is. You just use a Bowley gauge, and it's a metal Bowley gauge. You sterilize it a zillion times. But not for the Bolton norm. No, you're not going to get the Bolton norm out. But you don't need it when you can use the measurement, because that you can document. You say, look, your kid's face is already 8 to 10 millimeters too far down and back.
Shanna Baldwin just asked, what's the ideal age to start evaluation and treatment planning? As soon as symptoms are noted, parents and/or practitioners?
At the earliest age, anything. I mean, one of my mini residents from Iowa just posted a case of a 2-year-old girl with a deep bite like this, and I'm fully supporting him. Not just recognizing the girl's got apnea, and you look at her face, she's the cutest kid in the world. You wouldn't think it would happen, but she has apnea, and her face really isn't that far back. But if she's got apnea, you need to be treating at that age. You can't wait. You have to go in there and do it. And that's, and you with in the myo, you can get the kids really young. And those of you who have the behavioral skills, you can work with those kids, and that's the important thing. You're more important than I am in this airway war, and there should be more of you than orthodontists in the world. There should be zillions of you doing this stuff.
Are you meaning myofunctional therapists?
Yes, exactly. Myofunctional therapists. This is what you should be doing, getting these kids to become nasal breathers, and so many of them are not, and get that tongue to the palate. The problem here is when you see some of these kids and they have these tiny maxillas that look like they're caught in an elevator door. I want to wish you good luck with trying to get the tongue to fit there. And that's why you need someone who's going to listen to you. And, in 5 months, I can take a maxilla and mandible like that and expand it 10 millimeters. They just do it. A removable upper expander and a fixed lower expander. 5 months later, you've got a 10 millimeter increase in the width. Then we put some appliances in to hold it. And that's when the myo can really help. Now you can get the tongue there and keep it up there.
We have a lot more comments and questions. Trisha, you just asked, can we share this video with others? We're actually going to post this on our AOMT Facebook page, and so people can tune in. And I just sent a link out as well, because we will have updates about where to find things, etc. Some more questions coming in about where do you find an orthotropic specialist? How do you learn about this? In Europe, is this a thing? Enlighten us.
There's not a big group of us doing this. Unfortunately, John Mew is basically retired. Mike Mew is his son in England. Yeah, and there's a huge antagonistic profession trying to keep them from doing anything. I don't want to even get into that. So it's not being done much in Europe. There are a few people, isolated practitioners around the world. I've had a mini residency where I've taught this, and there are a handful of people who really understand how to do it well. My new course starting in May, it's going to be in Dallas, Texas, and we're actively promoting it to pediatric dentists, orthodontists, general dentists who do ortho. And I'm going to mentor the people with this, and my job is to hold their hand along the way. It's not, they can't come in 2 days or 3 days and me lecture all day long and then they walk out and do it. It's not going to happen. Well, I always joke around and say it's like learning to fly an airplane. You don't go out and take off a 747 the first day. So I'm actively seeking people to sign up for this course in Dallas in the mid part of May. Please go to Orthotropics -na.org to find more about this.
More about those practitioners.
Pardon me? This is about practitioners who do this. There are a handful. Orthotropics-na.org as for finding practitioners who do it. You'll be lucky to find very many, because there are only a handful that really are doing it. My goal is to teach a whole lot more people, and my new mentorship is meant to be more effective at doing that, because it's not easy to do this. It's not easy for the doctor. It's not easy for the kid, and the parent. The parent is pivotal in the support process here to get it done. And myofunctional therapy is a critical part of this whole thing. If they don't change their rest oral posture, nothing that I as an orthodontist do is going to be stable at all. They have to become nasal breathers. They have to have their tongue to the palate.
Before we're done, I would like you to get that link, and Mark, please jump in. Mark Moeller.
What a privilege this is to be a part of this discussion, see texts and chat flying in from all over the world. And Bill, you were right saying good evening, because there are a lot of people, it's evening, they're watching this.
Okay.
And I just came back from the World Sleep Congress in Rome. And in one of our symposia, we announced something that this is going to get out there. This information cannot be contained. So we announced in one of my symposia that the European Respiratory Society, which is one of the preeminent medical societies in the world, probably the top one in Europe, is going to be helping sponsor. We're going to start, I think, with 10 countries, public service announcements, websites, social media. We'll be making television commercials available. We'll be filming this. We have a target deadline for March of next year on what patients need to know about myofunctional therapy as it relates to sleep apnea. And so this early intervention, these kind of concepts, we're going to be taking this on squarely and going directly to the public. This is something we've been building towards for years. This is going to be really exciting public health opportunity. And Luca Roberti is head of a task force for the European Respiratory Society. This is going to come out in Germany, Austria, Norway, Sweden, United Kingdom, Iceland, Italy, Belgium, and France. Did I say United Kingdom? That's just a start. And this is going to, we'll have opportunities to touch people in the United States as well as other countries around the world. So people are going to start asking questions. People are going to start demanding this. So there's not going to be enough myofunctional therapists to go around, nor will there be enough people like yourself. Thank you for your leadership, Bill. Looking to do early intervention as early as possible. This is an extraordinary time we're in, and there's going to be a lot of exciting opportunities for all of us ahead. So thank you all for being here today.
I might add, there are already 4 documents. I'm thrilled, Mark, that you're doing this. But this profession will change. The word is going to get out there. There are 4 documentaries that have already been started, and a 5th is in the works. We're looking at various aspects of what we just presented here. The world will change. It's going to change, and we've got people like Mark who are going to make it change. I can't thank you enough, Mark, for pushing this whole thing forward. And those of you who get in on it, you're really going to be healthcare workers, because this matters a lot.
People are wondering about the link for your residency. So do you have that? Ask Debbie for it. I know
it's ortho2health.com.
Okay.
Ortho2health.com. And if you have
Ortho number 2.
Yeah, ortho number 2 .com. If you can get pediatric, the best market is pediatric dentists, to be honest with you. We've been marketing and pushing like crazy our efforts to fill the class in this new mentorship. And I'm sorry, but the orthodontists are not really responding hardly at all. It's very disconcerting. Pediatric dentists and general dentists doing ortho. If you can get an open-minded orthodontist, boy, please send them. It'd be in your best interest, that person's best interest, and the patient's best interest.
And, there's been other questions around lingual palatal or lingual releases, how this impacts growth. These are all these fine nuances. We run programs, as you know. We just started a March cohort. I was very excited that you were coming in to explain this, the orthodontic understanding, because it reinforces what we're working on in terms of growing the face through the tongue with closed lips. And I always love to quote you about saying, if the tongue was up and the lips were closed, we wouldn't need orthodontists. There wouldn't be a need for that. Yes and no. We all know there's complications along the way, but the development, the form, there's a lot of underlying pieces to this puzzle. But yes, please, if you know people who are interested, and we need them trained, especially with this mentorship that you're launching, Bill, and we really invite you to seek more information. So please spread the word. If you want to get updates from us, I'm putting in the chat this link. Just to opt in, you'll get updates, events, all that stuff that we do at the AOMT. And we really see how many people are in the room. People are interested. So we need to get this to the right people, and that we can work collaboratively and have a larger network to provide to.
I thank you, Samantha, and all Joy and Barbara and the other ones who really tuned me into all of the lingual, the tongue tie issue, because I was a doofus. I knew nothing, but I couldn't be more of a believer in it now, and I can't thank you guys enough. I'm a huge supporter of that.
We know you are, and it's actually the people who come through and from you are teed up. And I think that's really a critical piece of this puzzle. What's the best case from a myofunctional therapy perspective? It's when they walk in your door and they already get it. And so you really help people get it, Bill, and it makes it so much more enjoyable and easier from many levels. So we want to spread this information so people can get that educational interaction with their primary care physician or dentist or orthodontist as well. So thank you. Anybody want to add anything at the end here?
I just wanted to thank you, Bill, so much for this talk. And what I heard you say, which was so critical to me, is there is no cookbook. You have to think. And that's why our coffee clutch and our ongoing support is so critical, because there's so many nuances and developments and appliances that doctor, how do you work with this that appliance? Yeah, like mind-boggling. But I want to thank you for always being there to support and help.
Well, thanks, Joy.
Yeah, it's great to have the the support embedded in the provider and patient relationship. So everybody, I want to say thank you for coming today. This has been a treat. Please refer to those links. Thanks for everybody who's doing what you do to move the needle. I know we have a lot of experts in this room, so we all appreciate you coming, and we'll have more events like this, and please let them know about the residency, the mentorship program, and we really appreciate you being here today. So that's it for now, and you'll hear from us in the future. Bye, everyone.
Thank you.
Bye.